Yeah, this is the Putra case.
Okay, so this patient is a 67-year-old man. Actually, this patient is the one that the resident described as he was yanking the tree branch and he sustained a pain in his shoulder. So his complaint is night pain. His complaint is pain during overhead movements, but he doesn't complain of any weakness. So we can proceed with the examination.
Okay.
So in the examination, we will see that the range of movement, actually, there's almost no problem. It's almost equal to the other side. Forward flexion, adduction, even internal rotation, external rotation is quite okay. It's just that there is objective weakness when we do the Job test. But subscap and infraspinatus and even teres minor, all are normal. There's no bicep tendon problem. Impingement tests are positive. So he has positive Neer and Hawkins test. So we send him for an X-ray. On the X-ray, actually, the AP and Rockwood views look quite okay, but when we zoom in and look at the subacromial space, actually, there's some calcification seen within the supraspinatus tendon.
Yeah, this is
and
so
there's a very
weird because there's no, you see, there's no suture size, right? No spur. Okay, you see some calcification. This patient, actually, I try conservative him for a while, but he's not getting better, right?
So when we actually zoom in, we can clearly see there's some calcification. Even there's an erosion of the humeral head, which you can see with some sclerosis on the X-ray.
Yeah, sclerosis, and you can see also
So
the
it's very
cyst.
small.
You can see the cyst
Yeah.
at the tuberosity insertion, right?
So we can see this again on the MRI, which is the next slide. So here there's a cyst. At the same time, there's a bursal site. You can see that there's a signal change there, which signifies there's a bursal site tear. The articular site looks intact.
Yeah. So this is so weird. The cyst is quite big, right? And the rotator cuff signal is look weird.
So we proceeded. The plan was we thought it's a partial bursal site tear, so we plan to repair it and also to maybe break the cyst to allow healing. So this was our plan when we went in. So we are making the portals now. The portals are standard posterior, anterior, superior, which is just in front of the AC joint, and two lateral portals for viewing and for working. So inside the joint, actually, mostly everything looked quite normal. This is a supraspinatus tendon from the articular side, looks quite intact. And the next we will look at the biceps tendon. No issue. Even the biceps pulleys are quite nice, and there's no pathology seen.
Yeah.
Subscap was okay, but it's not seen in this video.
So this is the bicep pulley. You can see that here, bicep. This is HGSL, right? To form the bicep pulley. It look nice, and also the bicep is not inflamed. So we switch the camera right into the subclavian space.
Yes.
Yeah. And that
is the CAL.
Yeah.
The CA ligament. So we started to clear the subacromial spur, although it's quite small.
Yeah, it's very small.
Decompression.
It's also flat. But actually, this patient, you don't need to do the decompression. I think it's very small, okay? But for sure, I need to make sure that there's no spur. I do very minimal decompression, right?
So again, decompression is done in two planes from the posterior, and then we check from the lateral and decompress from the posterior.
Yeah, always looking to plane, because you have the three-dimensional idea. Yeah.
We can look at the AC joint as well here from this view, but in this patient it was normal. So we started to clear the subacromial bursa and look for the tear.
Yeah.
And this was somewhere where we suspected there's a small fissure in the supraspinatus tendon, but we were not sure, so we started to look anterior and posterior by rotating the humerus.
So you can see some abrasion, right, on the supraspinatus. Even the acromion spur is not bad, right? I found some patients like this. Even there's no spur. Okay. But anyway, the supra look not too bad. So at that time we discussed with the team, right? What should we do next? Because it look just abrasion. Okay,
We
acromion also
decided to
not
do
bad.
to break the cyst and do a trepanation of the tendon
Yeah, right.
to allow some healing.
Yeah,
But
right.
at this point, we were suspicious of some scarring at the subscap area, so we were
Yeah,
trying to
right.
release
This is
that.
a coracoid process. We call this colocoplasty. You see,
Mm-hmm.
this patient we're not sure, so we do some colocoplasty, and the cup looks so inflamed. So we follow the bursal side. That we try to do the trepanation to improve the healing, right? So then I try to make a microfracture into the cyst.
Of the cyst.
Yeah, into the tuberosity. Okay.
But during this time, we realized that the supraspinatus actually is quite poor quality and not very well fixed, and there's some calcium deposit within the tendon also.
Right.
So we continued to explore this area, and we found there's actually a large tear, intrasubstance tear.
Yeah, this is intrasubstance tear. Okay.
So the articular fibers look okay.
Yeah.
So we cleared the footprint and.
Yeah, you see that there's a big hole there. See?
Yes.
Yeah, there's a big hole there.
So we expose the entire cyst, and then we start to look at the rim of the cyst leading towards the articular surface, and actually there's an articular defect also. So then we proceeded with.
So actually, I'm not sure I'm doing too much. Yeah, because in the past, I dare not do this at all. Okay, in the case that have the intrasubstance tear. But this patient, the pain is too much and we cannot find the cause of the pain, you know. We cannot find it. Acromion is not bad. Okay, the bicep is also good. You lick from the joint is also fine. Okay, you see the big cyst, you see calcification. Okay, so I think for a while and finally I think I need to do something. Otherwise, the patient may not be better after the surgery. Okay, so we decide to take down. Okay, yeah, but I think I do the right thing because now the patient feel much better. Okay, so I take down, okay, and break the cyst using the microfracture. You see that? It's so big. Yeah, we break the cyst. See? So
yes, very big.
So the lateral anchor is not the problem. What is the medial anchor? How about the medial anchor?
I think if we use the some of soft anchor and the hold didn't last enough, I think it can hold the defect.
Okay, so the anchor you should not put into the cyst. Okay, you try to put it close to the articular surface. You see that? And the direction you should point it to the subchondral bone. You see that is the anchor. Okay, away from the cyst. And also the direction. You always get the good bone. Okay, so I have no worry about that. Do not put it on the close to the cyst and also the direction. Put it close to the articular surface. Okay, because most of the cyst is will not extend to the close to the medial footprint. Yeah, so try to put it close to the cartilage.
During the case you had mentioned also, Dr. Bancha, that if you really don't have space, you can put the anchor to the opposite cortex.
Right. We have
bury
done
it
that
quite deep.
also. Yeah, if you use the why not or the something like this. You can put it to the far cortex. Okay, you can put it deeper also. Okay, but is it possible? I tried to put it on the underneath the subchondral bone. Good.
Okay. So after we have done the medial row, so we are passing the sutures now through the cuff. So we have put two triple loaded why not anchors into the medial row. So now we're going to pass them as pairs. So we have 6 pairs going from anterior to posterior. So this is how we are passing the pairs. We use spectrum and also the mini first pass as well. And we're taking a big bite.
Yeah.
To avoid cut through of the tendon, because this patient has some calcified material within the footprint of the tendon.
Yeah. So try to make a big bite, and the distance between the suture, you should make it equal. Okay. And careful the bicep, because we did not sacrifice the bicep for this patient, right? Okay.
Later, actually, in between, we actually went in to check whether we have caught the bicep.
Right.
Between the bites, we actually put the scope in through the defect to check.
Always put the scope in to check your bicep. You see that? It's safe, right? Not just the bicep. You need to look in the groove also. Sometimes I have one patient, I catch the bicep. Okay, I need to cut that suture. Okay, and then tie the knot.
You mean you have to bring the patient back to cut the suture?
Yeah, I put in the joint, and then I put it too late. I need to cut one suture that catch the bicep. Okay, but the red is strong enough.
So now we are tying, but we are not going to tie all, because if we tie all the limbs, we will strangulate the tendon. So we alternate tying and don't tie, tie and don't tie. And we use non-sliding knot here because we don't want to cut through the tendon.
Okay. So we tied one in the front, one in the back, one in the middle. Okay, about 3. But if the patient are L shape, I will tie the apex also. Okay.
Okay.
I stopped using the knotless because we found the problem that if you didn't tie the knot at all, you will have some gap underneath. Okay. So nowadays we use the high bridge. So this one we tied 3, I think. Yeah. And then for the lateral row, right?
Yeah. So for the lateral row, what we are doing is we are grasping one of each pair and bringing it anterior and one to the posterior. So our main thing is that the placement of the anchors will be anterior will be close to the bicipital groove and posterior is close to the posterior cortex. And the distance inferiorly will be as far as you can go, but not too inferior. So I think around the area of the deltoid insertion.
Yeah.
And then we tension each limb separately before final tightening of the anchor. And the same thing is repeated. This is anterior, so we repeat the same thing for posterior.
Yeah.
So actually that's about it for the repair. For the rehabilitation wise, because it is a complete tear, I think we will treat it as not massive, but just as a single tendon tear. So we can probably get away with 4 weeks of immobilization before we start range of movement.
So this is we can say this small size tear, right? So the small size I immobilize for 4 weeks. Okay. For the large size tear or medium size, 6 weeks, right? For the massive, it's about 8 weeks, right? 8 to 10 weeks. You see that we put the scope into the joint, you can see the gap at all. You see, because we do the high bridge. Okay. If you didn't tie the knot, when you put the scope in the joint, you can see some gap. Okay. If you didn't tie the knot. Okay, very good. Any questions? Thank you, Putra, for editing the video.
Thank you, Dr. Bancha.
Yeah. Lim, Lawrence, Soy?
No questions, sir.
No questions. Okay. Bang?
No questions.
No questions.
no question
Okay. Gong?
อาจารย์ครับถามหน่อยครับอาจารย์
Okay.
ถ้าสมมติไอ้ตัวซีดเนี่ยมันอยู่ใกล้กับโบนคาทิเลตจังชันมากกว่าเคสนี้ครับอาจารย์แล้วไม่มีที่เหลือให้เราปักแองเกอร์ที่ชิดเหมือนในเคสนี้ครับอาจารย์เราควรสลับที่ของแองเกอร์เป็นแบบหน้ากับหลังอย่างนี้ไหมครับอาจารย์แล้วก็ปล่อยให้
Gong,
ลงไป
you're
บนซีด
asking
เลย
about if the cyst is big, what should you do, right? So most of the cyst is not that big because we saw a lot of cyst. You see that? If you look at this, you see my direction. You see? I will go. My first medial anchor will be medial to the cyst. You see? You see my cursor, right? Okay. And the second anchor will be here. So the cyst is not the problem. Okay, Gong, you understand? Most of the cyst is at the tuberosity. It at the greater tuberosity at the medial footprint. Okay, so if you go this direction, or in case you're afraid of the cyst, you can go this direction. Gong, you can go this direction or this direction, right? Go getting close to the subchondral bone. You will be away from the cyst. Understand? Another one, you put it lower. Okay, you need to plan beforehand, and you'll be safe. I have no problem with the cyst. Okay, and try to use the small anchor. Do not use the anchor that need to big holes, need to tap. You know, use the small anchor, very strong, right? Like why not? I like why not very much. In case your cyst is so big, you can go this way, Gong. You can go down here. Gong, see? And you use this far cortex. Okay? You can stabilize it here. Don't worry. Okay.
ครับ
And if you're not sure, you can use the C arm to check where is your direction. Okay. Also, the same thing like the patient have the very soft bone. You can do this way. Okay.
So meaning
you can
the
put the anchor deeper. Okay.
so meaning the knot of the Y knot is anchored at the far cortex, is it?
Right. It's anchored on the hard bone. Subchondral.
Hard bone.
Yeah, or
Okay.
the underneath the cortex is fine. Okay. Okay, very good. Thank you, everyone.
Thank you,
sir.
Dr. Bancha.
Okay,
Thank you,
good
sir.
night.
Thank you.
ครับผมครับอาจารย์
สวัสดีครับ
ครับ
Everyone, thank you.
Bye bye.
Bye.